Welcome to author interviews at Gastrointestinal Endoscopy. I'm Dr. Glenn Eisen, the editor-in-chief of GIE. Today I'm with Dr. Julian Abrams, who's an assistant professor of medicine at Columbia University in Medical Center, New York City. We'll be discussing his paper, Positive Correlation Between Endoscopic Radiofrequency Ablation, Volume, and Response Rates in Barrett's Esophagus. Welcome, Julian.
Thank you.
How are you today?
Good, thank you.
So RFA has been around for a few years, and I've been involved in some of the studies. But surprisingly, no one has actually looked at how effective we are based on our experience level. So I think this is a welcome addition to the literature. What prompted you to consider doing this study?
Well, I mean, as you know, the outcomes, especially the short-term outcomes, are very good for RFA for treating dysplasia. And what we're really starting to see now is RFA is expanding pretty rapidly into the community setting. And we've really learned a lot, I think, especially from the colonoscopy literature in terms of provider level variability and adenoma detection rates and outcomes. And so what we wanted to do was to then take a look at RFA, especially since there's very little on quality measures in endoscopy for Barrett's esophagus, and to look at RFA and provider volume as a measure of provider variability to see if that correlated with outcomes.
Okay. Can you tell us a little bit about the study?
Yeah. So this was a retrospective analysis of about 600 patients who underwent RFA from 3 different academic centers. It was from Columbia University, University of Pennsylvania, and the Mayo Clinic at Rochester. And we collected data on basic demographics and clinical characteristics such as age, sex, Barrett's length, pretreatment histology. And then our outcome of interest for successful treatment was something we termed complete response to intestinal metaplasia, which is a measure that's been used in other studies. So this is CRIM, and this is defined as no intestinal metaplasia on any biopsies of the GE junction or tubular esophagus on the first endoscopy post-RFA.
Got it. Okay.
And so then we looked at which endoscopists performed each of the RFAs to calculate provider volume, and then we just looked at correlations between provider volume and CRIM rates.
Okay. So many of the endoscopists that were involved in this study are considered the experts in the field, and presumably their rates might be slightly different from what the other physicians would find. But what was the range as far as how many procedures some of the doctors have done?
So there's actually quite a big range. It was from 20 to 188 patients, unique patients who were treated with RFA. And so the CRIM rates actually also range from about 60 to 88% with a mean of 75%. So we had a fair range to be able to analyze.
Okay. And what correlations did you find?
So we actually found a strong and significant positive correlation between provider volume or RFA volume and CRIM rates.
Okay. Do you think at some point there'll be a threshold for doctors that perhaps should get further training or even stop doing RFA because their rates are below an acceptable level?
Yeah, that's a very good question. I think there's some more information that we still need. I think one, this still needs to be validated with larger groups of endoscopists. We only had 7 endoscopists in this particular study. And then we couldn't really analyze to see whether or not there was a learning curve until or not whether there was a sort of a plateau above which a certain number of RFAs need to be performed to achieve an acceptable CRIM rate.
Did this take into account their experience level before the population you looked at? Yeah,
so we did multivariable analyses, and one of the factors we included and adjusted for was experience of each of the endoscopists by various measures in terms of how long they've been in practice, what their overall endoscopic volume is as well. And then we also accounted for patient-level characteristics, including Barrett's length, pretreatment histology, and the results held up.
Was there an impact of the number of sessions you needed to perform to complete eradication?
That didn't seem to be the case, but I think one of the questions in terms of using CRIM as a metric for a successful outcome, it does depend a little bit on sort of the provider's practice pattern. So some endoscopists may treat the GE junction once and then biopsy to see if there's any residual intestinal metaplasia and then only retreat if there is, whereas some others may choose to treat twice. and that could potentially affect the CRIM rate.
Sure.
So I think some further research needs to go into figuring out what the right metric is to use for quality. We just chose CRIM rate.
Sure, and that's actually a fairly stringent measure because it appears in the literature that it's easier to get rid of dysplasia than intestinal metaplasia.
Exactly.
So do you think, based on your study and perhaps future studies, we will readjust what the expectation is for patients as far as intestinal metaplasia eradication? Because I have patients come in and they expect a 90 to 95% success rate and are disappointed if they don't get that.
Yeah, and I think there are certainly some unanswered questions in general about sort of post-RFA biology, and if there's just a little bit of intestinal metaplasia, how clinically significant is that? But I think more relevant to the study, we really wanted to try and assess, if this is being done a lot in the community, is it being done at sort of an acceptable quality?
Mm-hmm. Are you going to be doing subsequent studies looking at community-based physicians?
We don't have any plans to, largely because we don't really have access to that data. There are databases out there that could do this. I know, for example, the HALO registry.
Right, the large registry.
Yeah,
sure.
is one way to look at this, and I believe they last year reported looking at centers in terms of center volume, but they didn't look at provider volume. So certainly looking at provider volume would be a way to
Any
address
thoughts
this.
about looking at trainees? Seeing, how many, because there's a lot of literature as far as how many colonoscopies you need to do, how many EGDs you need to do to attain competence, how many RFAs do you need to do?
No, absolutely, and I think that's important. And I think if we can assess whether or not there is sort of a curve, and then maybe if you get to 50 patients treated with RFA, then you reach a plateau, that could be used, for example, as a minimum number of patients need to be treated to achieve competence. Still need to sort of figure out where that is, though.
Okay, well, thank you very much. It's been a pleasure.
Thank you.
Sure.